Unfortunately, with the right-sided tumors, we know that these tumors have a very poor prognosis regardless of their genetic profile, and so they tend to progress early. Most patients will start with a doublet, usually FOLFIRI or FOLFOX plus bevacizumab, and then when they fail, their second line would be the other regimen. So if they start with FOLFIRI, they go to FOLFOX. If they start with FOLFIRI, they go with FOLFOX, they go to FOLFIRI, and you continue the bevacizumab. In this patient, we chose to go with FOLFOXIRI plus bevacizumab because of the high tumor burden and symptom burden, and so we needed a higher response rate. And we went with FOLFOXIRI bevacizumab. So technically, when you fail FOLFOXIRI bevacizumab, then your next option would be either regorafenib or TAS-102 or an EGFR inhibitor. If you went with, say, FOLFIRI bevacizumab in the second line, in the first line, your second line would be FOLFOX bevacizumab. Then your third line, you assess the same options. Now, how do you choose between all these, regorafenib, TAS-102, and EGFR inhibitors? Now, again, we're focusing on the right-sided tumors. If this was a left-sided tumor, and I started with bevacizumab in the first line, then my second line is going to be an EGFR inhibitor. If I started with an EGFR inhibitor, my second line would be bevacizumab. On the right-sided tumor, as we discussed, those EGFR inhibitors have to fall down the line of therapies. And so the question, do you introduce it in the second, third, fourth line? Where exactly is the right point? And remembering that this was a RAS wild-type, BRAF wild-type tumor. Most of these are RAS mutated, or many of them are RAS mutated, and therefore this would not even be a discussion. But specifically in the RAS wild-type, BRAF wild-type, right-sided tumors, where do we introduce these EGFR inhibitors, whether it's cetuximab or panitumumab? The answer is frankly not clear, because most of our knowledge is really in the first line, to a lesser degree in the second line. There are some hints that in the refractory settings, there may still be some benefit from EGFR inhibitors. There's an interesting study that was presented and now about to be published called REVERSE study, which essentially looked at a sequencing question. Start with regorafenib, followed by cetuximab. Start with cetuximab, followed by regorafenib. So rego-cetux or the reverse, cetux-rego. The primary endpoint of the study was survival. This was a Japanese study, so it may, in some ways, it may not apply to what we do in the United States, or may not apply to our patient population, but nonetheless gave us a very intriguing finding. And that finding was that if you actually start with regorafenib followed by cetuximab, the survival benefit is a few months higher than if you start with cetuximab followed by regorafenib, regardless, by the way, of side, whether you're right or left. So on the right side, where there's a big question mark about the role of EGFR inhibitors, I take this study a little bit more seriously, although again, I think it needs to be reproduced at a larger level in the US, and it's in the works. So we will have more answers hopefully in the next couple of years on this. But at this point of time, I just look at this, I look at the data, say from Concur, that suggests that regorafenib may actually have a little bit more of a benefit if in patients who are less pre-exposed to biologics, i.e. VEGF and EGFR inhibitors. And you put all this knowledge into works, and from my standpoint, it would make sense to start with regorafenib and push cetuximab, panitumumab to later lines. In fact, I would say even after TAS-102. So my sequence in my clinic, the sequence would be regorafenib followed by TAS-102, and then EGFR inhibitors would still be used, but I'd use them in much later lines of therapy, just because, again, on the right side, there are big question marks about the value of these inhibitors. Once patients go through multiple lines of therapy, to 1 or 2 lines of extensive therapy, so in this patient, FOLFOXIRI, bevacizumab, or sequentially FOLFIRI, FOLFOX, bevacizumab, those patients, as they get to this third, fourth line, so the more refractory setting, they're pretty fatigued. They're tired of their chemotherapy. Their cancer burden continues to grow on them and makes it much more difficult for them to tolerate further chemotherapy. So they start off with a very difficult journey, perhaps much more difficult than they've had it in the first and second line, which makes treatment challenging. If we look across the board, whether it's regorafenib, TAS-102, whether it's FOLFIRI, FOLFOX, in second line and beyond, for most of these patients, the benefit at the median is small, although for the patients who benefit, they tend to benefit for a meaningful amount of time, but for most patients, the benefit is actually small. And that's because they start coming from behind because of essentially what they had to deal with from their prior chemo, but mostly because as we get through multiple lines of therapy, the cancer burden and I call the level of aggression become much more noticeable, and those patients have a harder time overall to withstand any type of treatment.